We're very fortunate Dr. Rita will be in the room the next few days. Not only do we have our activity going, but we also have a lovely keratitis wet lab happening and all these other activities elsewhere on campus. So thank you, Dr. Rita. We'll count on people catching Dr. Rita and team for any questions. Next, I'd like to introduce my co-chair for this session, Dr. Shailander Sabharwal, who may not need much of an introduction other than to say he works tirelessly to support the team at Dr. Schroff Charity Eye Hospital and many other hospitals around the region in designing and conducting research that really helps to enhance the community services of the institutions. Shailander.
Thank you, Dr. Susan. Welcome and good morning. I think what we'll go to the talks focusing on improving effective cataract surgical coverage and effective refractive coverage. Yeah, I think we have an excellent lineup of speakers, and we are giving quite a challenge because we're requesting you to stay in time, but also spare at least a minute for your challenges and learning, and maybe a minute for questions. So we'll start with Mr. Ganesh Babu, and I think most of us know him. He's been at Aravind for more than 35 years now, senior manager and LAICO, and he's basically looking into efficiencies, and I think he's the right person to start this session. Welcome.
Namaste and very good morning to everyone. So I'm going to present about our experience and pilot initiative on improving both eCSC and as well as eREC at Aravind Hospital, India. So all of us know, like WHO introduced two eye health metrics, eCSC and eREC, with a clear definition as well as the criteria for the both intervention as well as for the effective outcome, basically focusing on universal eye health. And in 2021, WHO endorsed a global target of 30% increase in eCSC as well as 40% point increase in the eREC. So when WHO introduced the goal target in 21, we at Aravind began exploring what needs to be done, whether we should do something differently or something more, and how to assess our progress towards the global target. Because both eCSC and eREC are the evaluation metrics, which could be assessed only through the community level surveys. And they are really expensive as well as time consuming. And also it can happen only rarely, that is once in 5 years or so. So we should focus like what we should do, and we assess the requirements to move towards the goal. And it is clear like both we need to improve access as well as the comprehension to quality eye care in order to achieve the target, which means like everyone in need of the eye care is able to access, and also everyone accessing gets complete care. Okay, these are the two important things we need to provide in order to achieve this particular target. So with this, and fortunately, like both are within the scope of eye care providers, and also this really opens up the possibility of monitoring at the provider level, continuous monitoring at the provider level. So with this framework, we aim to identify specific provider-driven intervention as well as the indicators for ongoing measurement of the progress. And we expect that effective implementation of these strategies at the hospital level can lead to a measurable impact at the community. So to guide our work, we conducted a comprehensive review of our current practices. Basically, we did the granular analysis of the data that we collected from a population-based cross-sectional survey, and also analyze our one-year data of one of our Aravind hospital in India. So this is the findings from the our population-based cross-sectional survey. So the study showed like 76% is cataract surgical coverage. That is 1,098 patients were operated out of 1,446, which gives 76% cataract surgical coverage. But out of the 1,098 who operated, only 775 got the effective outcome, so which brought down the eCSC to 54%, because 323 with the poor outcome, so we could not reach, the eCSC was only 54%. So as per the WHO, we need to achieve 84% target. So we explore what should be done, and particularly focused on what can help to improve the poor outcome patients. So these are all the some major findings that we found, like out of 323, 232 patients can be prescribed the glasses to achieve the effective outcome. But currently they are either not wearing, maybe due to they are not prescribed, or they are not purchased, or they are not currently wearing. And also we found like another 33 patients who could be treated with laser for achieving the effective outcome for the PCO. And remaining 44 patients can only be improved their vision with the other eye surgery only. So considering the feasibility and also the high impact, so if we focus on ensuring like providing the spectacle for all those who need after the cataract surgery, at least 232 patients could achieve the effective outcome, which can lead to effective cataract surgical coverage to 70%. And also of the remaining patients who are in need of surgery, if you take care of the 60% of them now addressing their needs, now another 208 patients will be benefited, so which again would increase, and overall we can achieve 84%. So to understand the detail at the provider level and what specifically we should do, so we studied 1 year data of our Aravind Hospital, Theni, so where we examined 165,000 unique patients in that particular year. And of them, 19,000 patients actually met eligibility for the cataract surgery, but we advised only 8,500 patients for cataract surgery. So which clearly gave us an idea like there is a high advice gap of 56%. And of the advice, only 5,000 patients underwent surgery. Again, it gives another gap of complaints gap, 40%. And of those operated, only 4,500 patients were followed up. So which means like there is a follow-up gap of 11%. Of the patient followed, 2,413 patient, 30 patients achieved uncorrected 6-12 and above. And of those who achieve with correction, only 1,188 patients only given spectacle, which leads to a quality gap of 20%. So the compounded effect of all these gaps, reduce the ECIR, that is equivalent to eCSC, to 19%. Okay, but what we really are trying to do is like if we can close the gap at least by 50%, we'll be able to achieve from 19 to 49%. We have to focus on like advising properly and also ensuring complaints and all those things. So we'll be able to achieve 49%, that 13% increase. And we did the same exercise for the refractive error also, and we found almost similar things. Like we studied 15,000 patient data, and them like 3,200 patients were with the refractive error, but only 1,600 patients are wearing glasses, correct glasses, which is 49%. And of those who need intervention, 1,633, only 566 patients were prescribed glasses on that particular day. There again, we can see the advice gap of 65%. And of them, only 396 purchased. Again, it gives a complaints gap of 30%. So here also, because of these gaps, the effective refractive intervention rate comes to only 61%. So which definitely, like we can all see, there is a greater opportunity for the significant improvement in the refractive intervention rate also. So to understand this further, again, what we should do specifically, we did the patient flow analysis to see the patient pathway, and we try to understand what we should do at each stage, both in terms of the capturing data, checking the data, and also confirming the details. So with all these insights, we came up with some intervention both to address the gap as well as for ongoing monitoring. For the gaps, we decided like we need to address, standardize the protocol, and also integrate real-time alerts in the electronic medical record system to notify whenever there is a deviation from the protocol. And for the metrics, we come up with the outcome metrics as well as the process metrics. So this is a model screen, like if a doctor there is a eligible patient with both visual acuity as well as with the cataract diagnosis. If he fails to advise, the system will show, okay, like, I don't know. Yeah. So this patient is meeting the criteria. Do you want to advise? Okay, if you want to advise, you can click yes. Otherwise, you can click no and give the reason. So far, we don't know why they do not advise, but once we implement the system, we'll come to know like what we should do exactly. And in terms of the metrics, so we are suggesting both for the cataract as well as for the refractive error services. Okay, for the cataract, we suggest outcome metric of effective cataract intervention rate as a proxy or equivalent metrics for the eCSC, which is accompanied by the process metrics to manage the variation and also the gaps like advice, compliance, and other thing. Similarly, for the refractive error, the outcome metrics, effective refractive intervention rate, the associated process metrics are prescription rate and compliance rate. So both together, no, it will work. And for the refractive error, we can use the same formula for the near vision also. So we may have a question, will this work in achieving the global target? So we are confident because most likely this should be possible because it both ECIR and eREC can be easily monitored at the provider level. And it is a win-win. Actually, beneficiaries also, they will get more patient will be operated and more glasses revenue also will be enhanced. But the downside is like this cannot be achieved without implementing IT-enabled electronic medical record system. And also we cannot directly correlate ECIR and eREC to eCSC and eREC. But increasing in ECIR and eREC at the provider level will impact the enhanced coverage in the community for sure. So the lesson here is like what we found is like there is a lack of awareness of the new definition itself. So which we think like we can overcome with the updated protocols and communicating and implementing among all the practitioners and also ensuring the adherence to the protocol. And we also realized like there is a lot of practice variation exists among the clinicians, which is leading to gaps, particularly like inconsistency in advising as well as prescribing the glasses. And we hope like with the robust electronic medical record system that can enable capturing essential data as well as providing real-time alerts and also a system for ongoing monitoring and implementing the system which will be able to achieve our goal. So together we can turn WHO's 230 goal into reality. Thank you.